Okay, welcome everybody. My name is Jenny Bess, and I'm the president of the Georgia chapter of the National Association of Pediatric Nurse Practitioners. And we want to welcome you to the last continuing education event of our virtual webinar series for this season. We're really excited to have you join us and are thrilled that so many people were excited about this topic and interested in hearing from our clinician expert this evening. For those of you who may be a guest joining us tonight or are new to NAPNAP, we are the state chapter of a national organization that is dedicated to empowering pediatric-focused APRNs in our mission to optimize child and family health. And again, we're thrilled to have you. I want to thank each of our board members for helping to make this virtual education series possible this year, starting with our President-elect, Daphne Stewart. She's been the one behind the scenes maintaining our CE accreditation and dispersing all the CE credits this year. So thank you so much, Daphne. Marlena is our wonderful communications chair who has been keeping you all informed through social media and our newsletter. And she's been doing a fantastic job at that. So thank you, Marlena. Casey has been keeping all of our membership lists updated this year so that everyone's getting all of this wonderful information and invites to all of our events. And Dr. Danielle Hooper was our first clinician expert actually in our webinar series, and both Stacy and Casey have also connected us with some of our speakers. So thank you all for the work that you've put into this series. We also want to thank our partner organizations like UAPRN for helping to cross-promote. So before I introduce our guest speaker this evening, I just want to share a few quick reminders. There's a ton of stuff going on at Georgia NAPNAP. This Sunday is our first wellness social. We're trying a virtual wellness event and hope you can join us. It'll be our first time hosting something on the weekend, but we're really excited to be doing an introduction to aromatherapy and essential oils. So it'll just be fun, informative. We hope you can join. May 1st is the deadline to apply for the student scholarship and to nominate either yourself or a colleague for one of our 2021 Georgia NAPNAP awards. We are giving out 2 awards, one for Outstanding Advocate and the other for Distinguished Member. And Casey, our membership chair, has been hard at work organizing this opportunity. So please do nominate someone that you work with. We know there are many deserving pediatric APRNs in the state. May 5th or 15th is the deadline to complete your interest form to run for the board, the Georgia NAPNAP board next year, and there are many positions available. And June 8th will be our meeting to do our elections and also a year-end celebration. So we'll be awarding the 2 chapter awards and also our scholarship recipients that evening. So we hope you'll join us. And details for all of this is on our chapter website, which you can find on the main NAPNAP website, or you can just go to community.napnap.org/Georgia chapter. All right, and then for just a couple housekeeping things, the chat box and the Q&A are open, so please feel free to plop your questions in as we go along, because we've got a double feature tonight with lots of great information, but we'll do our best to get to each of the questions. And then to claim your continuing education credit, be sure to keep an eye on your email tomorrow. You'll get a follow-up email from Zoom with a link to the survey. So without further ado, I am pleased to introduce our clinician guest expert this evening, Dr. Sobenna George, who is graciously sharing her time with us to cover both prediabetes and also treatment for type 2 diabetes. Dr. George is a pediatric endocrinologist at Children's Healthcare of Atlanta and an assistant professor in pediatrics at the Emory University School of Medicine. She went to medical school at Case Western Reserve University and completed her residency in pediatrics at the Children's Hospital of Philadelphia, and later her pediatric endocrinology fellowship here at Emory University School of Medicine. She is an absolutely wonderful physician and colleague and leader. I can say so since I have the pleasure of working with her and learning with her all the time at GA Endocrinology. She wears many hats on our team as our champion of telemedicine, our QI leader, and more. And so I just want to thank her so much for sharing her time and expertise with us this evening. So please join me in welcoming Dr. George.
Well, thank you very much for that introduction. I appreciate that. You can hear me okay?
We can.
All right. Well, thank you very much for having me for this talk. And I hope it's informative for everybody. And, you know, feel free, I'm a very casual person, so feel free to interrupt, ask questions. And Jenny, if you can keep an eye out on the chat box, because I'm bad at multitasking. Okay. All right. So we're going to talk about prediabetes and type 2 diabetes and the treatment of those things in our kids that we see. So let's jump in. So at the end of this, these are the objectives that I hope to cover. We want to talk about how we're diagnosing this thing, how we're treating it, how we are using specifically metformin, insulin, GLP-1 agonists in our children, and then how are we screening and managing our, the complications that they may see because of their type 2 diabetes. So just a reminder, I'm sure you're all aware of this, the difference between prediabetes and diabetes. So you can look at your fasting plasma glucose. So 8 hours fasting, you check a plasma glucose in your office. If it's less than 100, it's normal. If it's 100 to 125, it's prediabetes. If it's 126 and above, it's diabetes. If you just do a random plasma glucose, they're not fasting, but if they are symptomatic, polyuria, polydipsia, a level greater than 200 is consistent with diabetes. If you do an OGTT, so you get your baseline blood sugar, which is fasting, you drink this sweet drink. I'm sure if those of you who have children and you had to do that during your pregnancy, and then 2 hours later you check a plasma glucose again. If it's less than 140, it's normal. If it's 140 to 199, it's prediabetes. If it's 200 above, it's diabetes. And then finally you have your A1C. So A1C less than 5.7 is normal, 5.7 to 6.4 is prediabetes, 6.5 and above is diabetes. So if you look at just the prediabetes column, if your fasting plasma glucose falls into this range, that's what we call an impaired fasting glucose. That's what it's otherwise known as. And similarly, if after your OGTT, your 2-hour blood sugar is between 140 to 199, we call that impaired glucose tolerance. Okay, so that's what it means. Some people question which method is the best to use, etc. And ultimately, what gets used most often really is an A1C because it's the most convenient, right? You can just do that in the office. Well, at least we can. We can do it in the office when the kids come. The problem with A1Cs is that it's not really studied in children. This data is all based on extrapolating data from adults and health outcomes, okay? So A1C, not as much data, but it's convenient, so we use it. All right. So this is a question that I want you to think of. When you see these kids with prediabetes in your own practice, how are you managing and treating it? There's no wrong answer. I don't know, is this interactive? Can people unmute and share or? Not really?
Raise their hands, and if anyone, we can give them video or speaking privileges, yeah.
Oh, I see. Well, I don't know if anyone wants to raise their hand and volunteer and let us know in your practice when you see prediabetes, how do you treat? What do you do? When do you treat? Any ideas? There is no wrong answer, I promise you.
If you raise your hand, I can allow you to speak, so don't be shy.
Any takers? If not, I'll keep going.
Oh, let's see, do we have a hand? Yes.
Okay, thank you.
Right, Stacy?
Can you hear me?
Yes.
We can.
Okay, hi, Dr. George.
Hello.
So what I try to do is offer them advice about diet modifications and trying to increase exercise as a first step.
Okay, all right, so healthy lifestyle changes, you stress that. Do you do metformin in your practice?
Personally, I have not, but some of the physicians I work with, they have some patients that they have started on metformin.
Okay, and do you know what threshold they use to start the metformin?
I'm not sure.
You're not sure, okay. Okay, Anybody else? Okay, well, we will keep going. All right, so how common is prediabetes, amongst our youth in this country? So this study was published recently in 2020, looking at an 11-year time span, looking at the prevalence of prediabetes, and it was a cross-sectional study using survey data. And they got survey data on more than 2,000 adolescents less than 19 years old. And they found that 18% had prediabetes. Okay, so that's a little bit less frequent than 1 in 5, but that's pretty common. Okay, so that means that everyone is seeing kids with prediabetes in their practice, pretty much. And they found that it's more common in males, in those who are obese, especially if it's central obesity, those with elevated blood pressures, and those who have dyslipidemia. Okay, so patients might ask you, why do we care, right? We care because we know prediabetes increases your risk for type 2 diabetes, it increases your risk for kidney disease, and it increases your risk for cardiovascular disease. This is why we care. So given that prediabetes is common, given that prediabetes increases your risk for development of more significant disease, what can we do to prevent the delay, or not the delay, to prevent the progression rather, of prediabetes to type 2 diabetes? The truth is, the information on this is all in adults, and it's based on this DPP study. This is a kind of like a landmark study in prediabetes management, and it's all based in adults. It was published in 2002, okay? So in this study, it was randomized, huge study, 27 centers in the late 90s. They had more than 3,000 participants who had some form of prediabetes, either impaired fasting glucose or impaired glucose tolerance. And there was a widespread in terms of race and ethnicities represented. On average, people were about 50 years old. Everyone was obese by adult standards in terms of BMI. And people were assigned one of these 3 categories. So either you were in the standard lifestyle and placebo group. So standard lifestyle is kind of like what you and I do in clinic, right? We see someone, we spend 10, 15 minutes, talk about lifestyle changes, you should exercise more, and then we see them again in a year, right? That's like what we do. Is that effective? Oh, I don't know. The next group was standard lifestyle changes, but they also put them on metformin. And then the third group was the intense lifestyle changes. So what is considered intense lifestyle changes? These patients were expected to lose 7% of their weight within a 6-month period. And to do that, they had to be involved in this 16-course curriculum over the course of 6 months, where they got real good advice on low-fat diets and all of that. They had to do 150 minutes of physical activity a week, etc. Okay, so intense lifestyle changes. After they had this 16-course curriculum, they were followed once a month throughout the course of this whole study. So intense follow-up, okay? And the whole point is, when you look at these different arms, how many of these patients go on to develop full-blown type 2 diabetes? And so they monitored fasting blood sugars periodically, they monitored oral glucose tolerance tests, and in general, followed these patients for 3+ years. So how adherent were the participants? So in terms of metformin, we all know that metformin causes upset stomach, right? That's why people stop taking it most times. So in terms of metformin adherence, about 72% of them took some form of metformin along the way, of which 84% took the full 850 milligrams twice a day. In terms of lifestyle adherence, 50% achieved that 7% weight loss in the 6 months, but by the end of it, some of them gained back the weight, so it was 38% by the end. In terms of physical activity, in the beginning, everyone was gung-ho. 74% people were doing the physical activity. By the end, it was 58%. So when I look at that, I don't think of that as like a failure, really. I think of that as what happens in real life. We all make these New Year's resolutions. We're going to go to the gym and work out. So January, every day we're in the gym. By the time we get to April, maybe twice a week is a good week, right? So this is kind of reflected in this study as well. So with these different arms, in terms of the weight loss that was experienced, so it was about 0.1 kilos in the placebo group, about 2 kilos in the metformin group, and about 5.6 kilos in the intense lifestyle group. And with that, this is what they found. So this is the years that they were followed throughout this study. And this is how, like the incidence of diabetes, full-blown diabetes. Those who were in the placebo group and just got like our advice once a year, they had the highest incidence of type 2 diabetes. Those with metformin were kind of in between. Those with the heavy lifestyle changes, they had the least or the lowest incidence of type 2 diabetes throughout the course of this study. This was a huge finding, okay? Put in other terms, if you compare to the placebo group, those in the metformin group were 31% less likely to get type 2 diabetes, but those in the lifestyle group were 58% less likely to get type 2 diabetes. So I talk to my patients about this, and I tell them, listen, in this study, even though people weren't 100% committed to this intense lifestyle group, right? Even though, you know, we got down to what, 38% doing physical activity at the end of 150, at the end of the study time period, even with that, the progression to type 2 diabetes was most delayed in that intense lifestyle group, even more than metformin. So we cannot stress lifestyle changes enough, okay? So that's in adults. That was a very encouraging study. In adults, we know that the progression from pre-diabetes to type 2 diabetes is about 5 to 10 years, but in kids, it's much quicker. So less than 2 years, that progression happens, okay? The problem is we don't have those kinds of studies in kids as we do in adults. There's no randomized control study comparing insulin to metformin to lifestyle changes to placebo in children. Most studies tend to just focus on obesity prevention. So that is the dilemma that we face. The best study that we have is from the RISE Consortium. They looked at kids who either had prediabetes or recently diagnosed type 2 diabetes, and they looked at the beta cell function. So just to remind you, your beta cells are in your pancreas, and your beta cells are what make or produce insulin, okay? People who have type 2 diabetes, or any diabetes for that matter, the beta cells in their pancreas don't function well. So in this study, they were trying to look at, okay, let's put some kids on insulin and metformin, let's put some kids on just metformin, and let's measure over time how well their beta cells work, because that is kind of like an indirect or proxy measure of kind of like progression of your diabetes. So that's the whole premise of this study. So they thought that, you know what, if we have them on insulin and metformin, they probably would do better than just metformin alone in kind of preserving how well these beta cells work. Randomized study, this time it was adolescents, all overweight, all pubertal, either with prediabetes or type 2 diabetes at the onset. In the first group, kids were given Lantus for 3 months and then 9 months of metformin. In the second group, they were given metformin the whole time. And I'm focusing just on those with the prediabetes, that part of the study. So what did they look at? So the medication was then discontinued after the 12 months in both groups. And then 3 months later, they assessed them again. So how well did they do even when they came off the medication? Okay. They measured A1Cs, OGTTs, and something called a hyperglycemic clamp. Just suffice it to say that a hyperglycemic clamp is something that's used a lot in diabetes research, and it gives you an idea of insulin sensitivity. So for example, if I maintain a blood sugar of 80, and it requires me to secrete about 100 units of insulin, but you can maintain a blood sugar of 80, and you can maintain it by only secreting an insulin, maybe 50 units of insulin. That means it takes you less insulin to achieve the same blood sugar than for me, which means you are more insulin sensitive and I am more insulin resistant. So you don't want to be insulin resistant. You want your insulin to work really well, right? So the hyperglycemic clamp gives you an idea of how sensitive your insulin is by looking at how much insulin you produce to maintain a certain blood sugar level. That's the premise of a hyperglycemic clamp. So this was measured in this study. So just to summarize it, this study was not hopeful. Basically, no matter which group you were in, your beta cell function declined. And this is in a short period of time, right? We said 12 and 15 months, this was noticed. Both groups were equally bad. And interestingly, this is not really statistically significant, but it is interesting to note that even in this 15-month time period, 3 people already developed type 2 diabetes. They went from the pre-diabetes to the diabetes on the spectrum, okay? So what do I do with all this information? Here we have adult studies that are promising. We don't really have the information in children. So what do we really even do in kids? Well, first, just to summarize the points that we talked about, know that prediabetes is common. Know that we care because of the risk of more significant disease. Know that the progression from prediabetes to type 2 diabetes is much quicker in children than adults. Know that the studies that we have are in adults. Unfortunately, that's how pediatric medicine is. A lot of the studies are done in adults first, right? Know that the studies in children, they're limited. Metformin and insulin may not be as useful as we think they are in delaying that progression to type 2 diabetes, and we don't have good studies comparing different treatment styles, okay? So what do? Me personally, I stress a lot about lifestyle changes. I can't stress that enough. But I do tell parents, this is based on the adult data, but this is the best we have, okay? So in terms of metformin and when to start it and when not to, the reason why I went through all those studies was just to make sure that you are aware of when we recommend beginning metformin, et cetera, it's not that it's based on this so much data in the pediatric population, right? So some people started A1C greater than 6, that's just my threshold. Some people, if the patient gets an OGTT and the OGTT showed impaired glucose tolerance, they start the metformin. So people have different thresholds. Just know that there's no science behind this, at least for children, okay? We don't really know if this is making a difference because the progression is so quick in children anyway, right? But despite that, we all have anecdotal stories. I have many stories of kids who they were in the prediabetes range. We worked on healthy lifestyle changes. We started some metformin, and within a year or 2 years, they were able to come off medications and stay off medications. So I think because of everyone's personal experiences, we still continue to sometimes prescribe medications, even in this gray zone, prediabetes, okay? So that's the prediabetes portion. Anybody has questions on that? If not, we'll jump into the type 2 diabetes portion.
Feel free to put any questions in the Q&A or in the chat box.
Okay, no problem. So we'll keep going, and at the end, if questions come up, feel free to ask. So type 2 diabetes. I put up on the side here how we diagnose it. How common is type 2 diabetes? Now, we talked about prediabetes. So this study looks at the incidence of type 2 diabetes in the youth in this country. And there's some take-home points here. Let me move this to the side. So this is years, 2004 to 2012. This is the incidence. And it's stratified by race and ethnicities, right? So we have Native Americans, we have Blacks, we have our Latino population, we have Pacific Islander here in the yellow, and at the bottom we have white. The purple is everyone combined. The big take-home points is type 2 diabetes is increasing over time, but the rate of increase is significantly higher for our Native American and our Black youth. It's disproportionately high for this population, which unfortunately is like many other parts of medicine, right? So I just wanted to point that out. Okay, so we talk about, how do we treat people who have full-blown type 2 diabetes? So this is not pre-diabetes anymore. So regardless, healthy lifestyle changes come into play because 99% of patients are obese or overweight that we see, okay? Not all, I do have some slender type 2 diabetes patients, but they are an anomaly. Most times they're overweight or obese. So there's metformin, there's Victoza, and there's insulin. And I just want to go through these 3 forms of treatment, okay? The goal is a little bit of a moving target. So what do I mean by that? Back in the day, they used to talk about what is your goal A1C. But now the thinking is more, how low can you get your A1C without having significant hypoglycemia? That's kind of what we're aiming for. What do I mean by that? So your A1C gives you an idea of what your average blood sugar is over the past 3 months. So if someone has a blood sugar that's always 100, then their A1C is going to look good. But similarly, if you have someone whose blood sugar is fluctuating between 340 and then down to 50 and then back up to 300 and then back down to 40 and then back up to 300 and back down to 30, their average blood sugar is still going to look good, right? And so their A1C is still going to look good as well. But that A1C is not as reassuring, because the reason the A1C looks good is because they had a lot of very low blood sugars, right? So you want a good A1C, but you don't want it at the expense of the patient having frequent low blood sugars. That's the point I wanted to make with these A1C goals. So metformin, probably I think everyone is most familiar with metformin. This has been approved for the past 21 years. It's kind of crazy to think that the year 2000 is 21 years ago, if you think about that. But anyway, it is approved for kids who are 10 years and older. Unfortunately, because obesity is so common in our children these days, I use metformin off-label because the youngest patient that I see with type 2 diabetes is 7 years old. So I have a 7-year-old on metformin for type 2 diabetes, okay? And I'm sure many providers can say the same thing. So the way metformin works is that it either prevents you from absorbing glucose, making glucose, and it allows your body, the peripheral tissues, to use the glucose more effectively in your blood. That's essentially how metformin works. There is not a risk of hypoglycemia with metformin, so that's one of the good things. Metformin can come in either the immediate release or the extended release. The immediate release, you have to dose twice a day. Extended release, you dose once a day. The problem with metformin is GI intolerance, like I said before. The immediate release metformin is more associated with GI issues than the extended release. So sometimes if I have a kid come in, they're on metformin, they're not tolerating it, a lot of diarrhea, I try and I switch them to the extended release metformin first to see if they tolerate that better. The problem is, most recently in the past, I don't know, year and a half or so, there have been many recalls on metformin extended release tablets. So because of that, to be honest, I haven't been prescribing extended release like I normally would. But if you do prescribe it, I would suggest that you call the pharmacist and make sure that they are dispensing a formulation that has not been recalled, okay? Metformin can come in both liquid and pill forms. Sometimes I use the liquid forms, you know, like for our kids who can't swallow pills, or maybe our kids who may have autism, etc. So it makes it easier for the family. Besides GI intolerance, everyone talks about lactic acidosis, but the truth is lactic acidosis doesn't really happen in an otherwise healthy kid. So it's more those people who have underlying issues, kidney dysfunction, they have hypoxia for whatever reason, they have studies using contrast dye. Contrast dye can affect kidney function, okay? So less common, the lactic acidosis. The time when that might come into play might be, for example, if a child gets admitted and they have metabolic acidosis for some other reason, they're sick in the hospital, then I might hold their metformin and not give it to them during that time until the acidosis clears, and they go home, and then I restart the metformin again. So that's kind of how it might show up. Vitamin B12 deficiency, to be honest, I've never seen this in children, and it could be because we don't see them long enough, and maybe adults see it more often than we do. But in theory, if you have vitamin B12 deficiency, you can have anemia, you can have neuropathy. So those are just things to just be aware of in terms of side effects, okay? So that's our metformin. You don't want to give it to people with kidney dysfunction or with acidosis for other reasons. In terms of regimens, this is how I prescribe it. So I ramp it up gradually. So I start with 500 once a day, and I gradually increase, normally by a week or 2 weeks, until I get up to the 1,000 milligrams twice a day, which is the maximum dose. And I always say take it with food. So I say start eating your meal, take the pill, then finish eating your meal. So it's really sandwiched in there in your stomach, okay? So this is metformin. Most people are familiar with that. Victoza. We were very excited about Victoza because this one got approved a couple years ago. It's for 10 years and older. Victoza is a GLP-1 agonist. So what does that mean? You and I, when we eat food, our gut secretes incretins. Incretins are hormones that our gut secretes to help our pancreas to work better, to secrete insulin. It helps to delay gastric emptying. It makes us feel full. It decreases our appetite. It also helps with weight loss. So Victoza it mimics those kind of natural incretins in our body. It's a GLP-1 agonist, okay? The problem with Victoza is that it only comes as an injection, okay? But it still was a great addition, because for the longest while, 20 years, we were only using metformin and insulin for our kids. So now we have another option to use. Side effects, GI intolerance, #1 side effect. Victoza, especially if used with insulin, can cause hypoglycemia. You can have pancreas issues, gallbladder issues, etc. The thing that people quote the most is this thyroid cancer, this medullary thyroid cancer. But the truth is, it hasn't really been found in humans. This was found in rats and mice, okay? So they were found to have an increased risk of developing medullary thyroid cancer, which is cancer of the parafollicular thyroid cells. So because of that, it is contraindicated in people who have a family history of medullary thyroid carcinoma or MEN2. So MEN stands for multiple endocrine neoplasias, and this syndrome is associated with pheochromocytomas and is associated with medullary thyroid carcinoma. So anyone who I'm thinking of starting Victoza, I ask, hey, any family members have thyroid cancer? Okay, and I do not begin it if there is a history of it. The dose, the maximum dose usually for kids is about 1.8 milligrams daily, but usually I start at the 0.6 and work my way up every couple of weeks, every couple of months, to make sure that they don't have GI intolerance with it, okay? Finally, insulin. Most people know insulin helps your body to use the glucose, decreases liver production. The problem with insulin, which is why I really try everything before I put someone on insulin, is that it causes you to gain weight. So imagine you have your kids with type 2, they're already having issues with being overweight or being obese, and now here you put them on Lantus or insulin, and it causes them to gain more weight. You know, it could be very discouraging for the patient themselves, you know, so I try not to do insulin if I can help it. And then the risk of hypoglycemia this is probably the highest risk out of everything that I talked about, all right? So normally, this is what our insulin production in our pancreas looks like. We make a little bit all day long, and then we make spikes of insulin for breakfast, for lunch, for dinner. And so we have many types of exogenous insulins, different peaks, different onsets, different durations at our disposal to help us to mimic what our body would naturally do. So we have many different types of insulin. But I think the most common type that we use, the regimen, is what we call a basal bolus regimen. So there's the long-acting insulin, and there are many different long-acting insulins. We have Lantus, Levemir, Basaglar, Toujeo. Toujeo is just like a concentrated form of Lantus. And then we have Tresiba, which is more like an extra long-acting insulin, okay? What I choose for my patients, for the most part, depends on their insurance. And then for the most part, 1 unit of Lantus is the same as 1 unit of Levemir, which is the same as 1 unit of Basaglar, etc. For the most part, there are some discrepancies. So I tell patients it's more like iPhone versus Samsung. You get the same effect, but it's like a different brand, okay? The bolus or the short-acting insulin, this is what you use with food. Many, many different types. And again, the type that we pick is based on insurance, okay? So we use this together to give 1 shot of long-acting insulin a day. And then for breakfast, for lunch, and for dinner, we give the short-acting insulin to cover the carbs in the meal. Some people with type 2 diabetes can get by with just Lantus and metformin, or just Lantus, metformin, and Victoza. But some people, even on all of those things, their A1C is sky high, blood sugar levels are very high, and so we have to add in meal insulin as well, okay? In those patients, they're getting at least 4 shots a day of insulin, okay? All right, I wanted everyone to be aware of this resource. So this is Standards of Medical Care. It's released every year in the American Diabetes Association online site. It's free. You can Google it. It comes up. And it's a great resource for both pediatric and adult medicine. And it goes through screening tips, diagnosis tips for diabetes, treatments, complications, screening, all of that is in this book. And in this book, they talk about how to manage type 2 diabetes based on A1C and based on whether they have ketones and acidosis, etc. So in terms of A1C, if you have someone type 2 diabetes, you have a strong suspicion, A1C is less than 8.5%, they just chilling, no acidosis, no ketosis, nothing, start with metformin. Work your way up to the 2,000 milligrams per day like I talked about. If it's greater than 8.5%, people do metformin and then they want to add something else. Now, I may disagree a little bit with this recommendation. So here it talks about starting insulin, but I will say if I had someone with an A1C of 9%, and I have them on max dose of metformin, I actually may try Victoza before I go to insulin, okay? And that's kind of like a style thing. But the ADA recommends doing like Lantus and metformin kind of thing if your A1C is above 8.5%. The reason why I don't jump to the basal insulin, like I said, is because insulin makes you gain weight. So I try to, not use it for as long as possible. The point I want to make here is no matter which regimen you're on, anyone who has type 2 diabetes, who you think has type 2 diabetes, you should measure diabetes antibodies. Diabetes antibodies are seen in type 1 diabetes. But the reason I say this is because back in the day, we used to say, if you're overweight or obese, you likely have type 2, and if you are thin, you have type 1. But the problem is everyone is overweight and obese these days. You can't just look at someone and be 100% sure that they have type 1 or type 2 just based on how they look. So you want to screen them for type 1 diabetes if they're obese, just in case, because the treatment for type 1 is very different to treatment for type 2. Type 1 diabetics need insulin no matter what, whereas type 2 diabetics, they can have different treatment thresholds. For the antibodies that I get, that you can order too, there are 3 that I like. I get GAD65, GAD65. I get the IA2 antibody. And then I get the insulin autoantibody, diabetes insulin autoantibody, those 3. On all of my obese patients who I think have type 2, I order those 3. This algorithm talks about if you're still not controlled, you can consider adding Victoza, etc., in addition to the metformin and the insulin, okay? Okay, finally, let's end with talking about complications. So we have the micro and the macrovascular complications. So we think about, I think more this, especially in pediatrics, I guess, but we talk about retinopathy and nephropathy and neuropathy. These are things that we are routinely screening for. So for retinopathy, we screen yearly at diagnosis and yearly. So if you are seeing someone who is not keyed into our program or whatever, which is fine because some people live very far away from our facilities or from an endocrinologist office, that's fine. Make sure that they're getting an eye exam every year, okay? For nephropathy, making sure that they're getting a urine microalbumin to creatinine ratio every year. It is best to use a first morning void to look for protein in your urine. That should be done once a year. And then I will send out these slides. It gives you the threshold for when you should start treatment. I'm not going to go through every single point, but just know that there are certain thresholds for when to start treatment. Neuropathy, performing a foot exam if you know how to do it, that should be done yearly. In terms of macrovascular complications, looking at things like cardiovascular disease, stroke, those kinds of things, we want to measure our lipid profiles yearly. And I'll give you the thresholds for when to start statins and, what thresholds we should look at. If you are not comfortable starting the medication, that is fine. But even if you were to screen, for example, if they've been lost to follow up and haven't seen their diabetes provider, you can feel free to get these levels and call us and say, this is what we found, and we can help start medication, adjust medication, etc. Hypertension, every visit. The important thing about measuring blood pressure is making sure that you have the right cuff size, especially for our kids who are overweight or obese. Many of them need adult size cuff size to make sure that the measurement is accurate, okay? And then fatty liver disease, that should say AST and ALT actually. ALT is actually better. And that should be done yearly as well. Because many of our kids, we have to refer them to the hepatologist because of that. So these are the complications that you are screening for, when to screen, how to treat, and I will send this to you by email. Finally, how common are these complications? The reason I want to include this is because many times families think that these kids aren't at risk for complications. That's something that will happen when they're 50, 60 years old. Why do I care right now, right? We hear that all the time. So this study was the Today clinical trial, another landmark study looking at how common are these complications in our adolescents. So they found, even at baseline, 5% of patients had LDLs that were too high. Within 3 years, 11% had LDLs that were too high. Hypertension, almost 12% of our adolescent patients at baseline, up to 33%, a third of them at the 4-year mark. Protein in their urine, an early indicator of nephropathy, 6% at the beginning, about 17% at the 3 to 4 year mark, okay? So the point is, complications are not uncommon. Screening is important. Not only is important, realizing that the risk of complications from diabetes are actually higher in our patients with type 2, for some reason, I don't know why, than our patients with type 1, even if they've had diabetes for a shorter period of time, okay? So I like to drive this point home to families and to parents and to patients. This is why you should care, and this is why you should care now. It's not a when I'm 50, 60-year-old disease, you can see complications now. I have 2 patients who are teenagers who are on dialysis because of poorly controlled type 2 diabetes, okay, teenagers. So, it is possible. So those are the main things that I wanted to talk about. I don't know if anyone has questions or comments or things that they have observed in their practice that they want to share. I'm open to anything.
We do have a question in the Q&A box
Okay.
about retinopathy and neuropathy. How often do you see those in your pediatric patients?
So retinopathy, to be honest, I've never seen it. Neuropathy, I would say I probably have about 3-4 patients who are on gabapentin because of significant neuropathy, and the patients are poorly controlled. It's not like the A1Cs are 7 or 8 and they have neuropathy. I'm talking about A1Cs greater than 14%, greater than 14%, greater than 14% for 2-3 years, and they have neuropathy.
And what would you say is the threshold for providers in primary care to refer to endocrinology?
So I think some of that depends on comfort level. I personally don't think that everyone with prediabetes has to be referred. I think people are perfectly capable of doing metformin with A1Cs greater than 6% if you're comfortable. If not, I would say refer if your A1C is above 6.6%, or if you have impaired glucose tolerance. I would not refer someone with an A1C of 5.7, 5.8, etc., because then you'll have to refer so many people. Okay. So yeah, that would be my threshold.
Okay, great. And do you recommend that the primary care doctor or providers do any other lab work before referring, or just that A1C?
I think it would be wonderful if you had an A1C, if you had diabetes antibodies, so GAD65, IA2, diabetes insulin antibody. I think it would be wonderful if you can do an OGTT. Some people think that an OGTT is a little bit more specific for diagnosing diabetes in our pediatric population than A1C. So an OGTT would be useful. I think those are good starting points, because I imagine that those patients would have already had like a CMP and a lipid profile because you would have done it with routine obesity screening labs kind of thing. So that would be a good start.
Okay, and we have another question. When do you typically recommend that your patients start using insulin pumps or other technology like continuous glucose monitors?
Okay, so some of this, sadly, depends on insurance. So it is much easier to get insulin pumps and continuous glucose monitors for type 1 diabetes than it is for type 2 diabetes. The other thing is age group. It is easier to get, especially for Medicaid patients, it's easier to get, especially CGMs in our kids who are less than 19 years old. So that plays a role into it. In terms of starting CGMs, I'll do it right away. If that would improve their compliance, because it's annoying to have to check your blood sugar all the time, especially for a child. So if I can get that, I would do it right away. Pumps, I could count on one hand. I don't know if I have any patients with type 2 diabetes on an insulin pump, to be honest. But if someone did go on a pump, I would wait at least 6 months before I put them on it, mainly because a pump can malfunction. It's a machine. And if it malfunctions, they need to know how to do the basic diabetes care. They need to know how to give insulin, drop insulin, and all of that. So I don't like people to become too reliant on a pump too early on.
Okay, thank you. And another question, if you see a hemoglobin A1C of greater than 6, but parents do not want to start metformin, how soon should you recheck that lab?
I would do it within 6 months. I wouldn't wait more than 6 months without checking it again. You mean the parents want to do some healthy lifestyle changes first to see, you mean?
Right.
Yeah, I would give it at least 6 months.
Okay, great. Any other questions out there? All right, I think those were all the ones that we had in the chat and the Q&A. Thank you so much for sharing this really useful information with all of us. We did record today's session, so it'll be posted on our website, and we'll be sure to share the information from your slides. So thank you. And everyone, to claim your continuing education credit, be sure to keep an eye out for that email tomorrow and complete the follow-up survey. And thanks everyone putting in your great feedback in the chat box. So you can see that too, Dr. George. Lots of folks really enjoyed it. Terrific, very informative. Thank you so much.
Thank you guys for having me. I appreciate you.
Awesome. Well, thanks everyone for joining us. We hope to see you this Sunday for the Wellness Social, and hope everyone has a great night.
Bye.
Bye.